Right, let's get straight into it. We're going to deconstruct the ECST-2 paper exactly as you would in your academic fever. This is the structure you must follow to show a logical and thorough appraisal. Let's begin with the clinical question. First up, you need to state the PICO. Be concise, be accurate. Laying it out like this shows the examiner you've immediately grasped the trial's fundamentals. So, the population, this was adults with carotid stenosis of 50% or greater. Now, critically, this included asymptomatic patients and symptomatic patients, but only those with a low to intermediate predicted 5-year ipsilateral stroke risk, that's less than 20%, calculated using the carotid artery risk score. The intervention was optimized medical therapy, or OMT, plus carotid revascularization, which could be endarterectomy or stenting based on local expertise. The comparator was OMT alone, and this was a properly protocol-driven intensive regimen. And finally, the outcome. This was a 2-year hierarchical composite. It started with the most severe events, periprocedural death, fatal stroke or fatal MI, then it ranked non-fatal stroke, non-fatal MI, and finished with new silent cerebral infarction on imaging.
Okay, we've defined the question. Now let's scrutinize the methodology. Can we actually trust these results? Let's look at the internal validity.
First, state the study design clearly. ECST-2 was a multi-center, randomized controlled trial. Now, you must acknowledge it had open-label treatment allocation. But, and this is the key point, this potential for bias was mitigated by blinded adjudication of both the clinical and the imaging outcomes. That's a huge strength.
An examiner will expect you to highlight these specific points. So, let's go through them. First, patient selection. Using that recalibrated CAS score was a major strength. It makes sure the trial really targeted a genuinely low-risk group. This strengthens the internal validity, even if, yes, it does narrow its applicability. Second, the randomization strategy. They used minimization with permuted blocks, a very good method to reduce any imbalance in important prognostic factors between the groups. Third, as I just mentioned, the blinded outcome adjudication by independent neurologists and neuroradiologists is a massive plus. It minimizes observer bias, which is absolutely critical for a somewhat subjective endpoint like silent infarction. And finally, the analysis was by intention to treat. This correctly handles any patient crossover and, it preserves the integrity of the randomization. You must comment on this. The COVID-19 pandemic definitely had an impact on follow-up. Specifically, it reduced the number of patients who got their 2-year imaging. Now, the point to make is that this impacted the study's statistical power for that specific endpoint, but it doesn't introduce systematic bias into the overall findings. It's an important distinction to make. Right. Let's move on to the statistics. This is a crucial area, and one where you can really impress.
You need to be very clear on this point. Why did they deviate from a standard time-to-event analysis? A Kaplan-Meier curve with a hazard ratio?
They chose the Finkelstein-Schoenfeld win ratio because the primary outcome was that hierarchical composite of events, all with different clinical severities. See, a standard time-to-event analysis treats all events as equal. This method is much more nuanced. What it does is it pairs up every patient from the intervention group with every patient in the control group, and then decides a winner based on who had the better outcome, according to that predefined hierarchy. It's powerful because it lets you incorporate different types of outcomes, like silent infarcts, in a way that makes clinical sense. A major stroke is rightly prioritized over a silent infarct. And what's really fascinating here is the result of all those pairwise comparisons. Just look at the enormous proportion of ties. Over 77%. This finding itself is so powerful. It brilliantly shows just how low the event rates are in this low-risk population when they're on modern, optimized medical therapy. In the vast majority of pairs, neither patient had an event, so it was a tie. And the actual wins, almost identical for both groups. The final reported win ratio was 1.01. So that number 1.01 is just the wins in the intervention arm divided by the wins in the comparator arm. A ratio of 1 means the odds of a better outcome are identical. But the most crucial point here is the confidence interval. A win ratio of 1.01 is basically neutral, and the 95% confidence interval of 0.60 to 1.70 widely spans 1. And that demonstrates no statistically significant difference, and therefore no evidence of benefit for either treatment strategy.
Okay. With that statistical framework in mind, let's turn to the results. For the exam, be direct. Focus on the primary findings.
State the top-line result unequivocally.
The 2-year interim analysis of ECST-2 found absolutely no evidence of a benefit of adding carotid revascularization to optimize medical therapy in this specific population. And this illustrates a key point you have to raise. While the primary composite outcome was neutral, the 2-year rate of ipsilateral stroke, the very event we're trying to prevent, was actually numerically higher in the revascularization arm. It was 6.2% compared to just 2.9% in the OMT alone group. Now, this difference didn't quite reach statistical significance, but it's a critical finding that really highlights that upfront procedural risk. You've got to briefly mention the harms just to show you've considered the full risk-benefit balance. In that intervention arm, there were, of course, expected procedural complications. These included a 4% risk of stroke within 30 days, MIs, a 7% rate of cranial nerve palsy after endodorectomy, and 1 peri-procedural death. This just reinforces that upfront hazard of doing the intervention. Now, you must demonstrate critical thinking by considering the applicability and the limitations of these findings. Who do these results actually apply to? First, these results apply only to patients with a low or intermediate predicted stroke risk, as defined by that CAR score. They absolutely should not be extrapolated to high-risk symptomatic patients. Second, the adherence to the protocol-driven medical therapy was exceptionally good, which, let's be honest, may not be replicated in routine clinical practice. Third, this is an interim analysis at 2 years. We must wait for the 5-year data to see if those curves diverge later on. And finally, a key part of the primary outcome was silent infarction, which is a surrogate endpoint. Its direct translation to future clinical events, well, that's still up for debate. And finally, you deliver your conclusion. Do it with confidence, just as you would to the examiners. Start with a bold summary statement. ECST-2 is a well-conducted and clearly practice-influencing trial. And explain its core impact. It provides level 1 evidence that challenges the traditional way of thinking, that stenosis-based decision-making, and instead it supports a more individualized, risk-based approach. So give the clear, actionable clinical takeaway. The conclusion from this 2-year data is that in carefully selected low-risk patients, optimized medical therapy alone is an appropriate initial strategy, and carotid revascularization can be safely deferred. However, you must stress that intervention remains clearly indicated for higher-risk patient populations who are not included in this trial. So in summary, this is a methodologically sound paper that addresses a highly relevant clinical question. Your appraisal shows a clear understanding of trial design, statistical analysis, and clinical application. It's a clear pass.